We are interviewing today the Dr. Ester Orlandi, who is the chief of the clinical department of the National Center of Oncological Radiothérapie in Pavia, Italy. Good morning, doctor.
Good morning, Sandrine, and thank you for inviting me.
I have some questions. What is the proportion of patients you treat that develop radiation toxicity now in CNAO and in our last experiences?
Radiotherapy represents the mainstay of treatment for several tumors, either in a curative definitive setting or in post-operative setting, and with or without concomitant systemic therapy. Acute and late toxicity are very frequent. In particular, acute toxicity, defining acute toxicity, side effects occurring during or within 3 months after the end of therapy, occur about in 50-70 patients receiving conventional photon-based radiotherapy, and severe late toxicity. About 10-20 patients can experience severe late toxicity, also considering photon-based radiotherapy. With proton therapy, these percentages are lower compared to previous techniques in light of specific physical and ballistic properties of proton therapy. The percentage is about 20% for late toxicity, although with this percentage can be reduced using proton therapy. And the majority of patients experiences acute toxicity, and up to 50% of patients has severe acute toxicity.
And what is the impact of these toxicities on the treatment of the patients?
Usually, patients are visited during their treatment, 1 a week most commonly. Patients' severe toxicity can negatively impact on patient compliance and all aspects of quality of life. In certain cases, patients can have unplanned interruption of their treatments, and in certain cases, toxicity, in particular acute toxicity, can require hospitalization. For some tumors like the neck tumors, severe toxicity during treatment can require hydration, drug administration, both opioids and anti-inflammatory drugs to reduce toxicity profile and to improve treatment compliance.
And how do you manage these patients with late toxicities?
These patients are managed in a dedicated way. So the appointments for follow-up visits are more strictly. These patients need to be visited within a multidisciplinary team. We need to involve other specialists, also psychologists, for example, because patients with severe late toxicity usually develop a certain degree of anxiety and depression. And for these patients, psychologist counseling is of pivotal importance.
And in your opinion, what would be the benefit to have this information of prediction of toxicity for patients upstream of treatment?
We could be able to estimate the risk to experience a certain degree of toxicity. So clinicians are able to optimize treatment and supportive care. This means a primary prevention of toxicity. For example, it would be possible to discuss if a radiation therapy can be avoided, if there are equivalent therapeutic oncological approaches, radiotherapy can be avoided. This is, for example, for surgery instead of radiotherapy. And the same way for patients with in situ breast cancer, we can give mastectomy instead of lumpectomy followed by radiation therapy. If it's impossible to avoid radiotherapy because this is a suboptimal therapeutic strategy, we can adapt radiotherapy treatment. For example, we can decide to reduce elective target volume, both in terms of extension, but also in terms of doses. We can decide to use hyperfractionation instead of conventional fractionation. It's even known that hyperfractionation has a protective effect on later reacting tissues. So this could reduce the burden of toxicity. We can monitor patient setup and organ motions during treatment and between sequential radiotherapy sessions in order to reduce the amounts of doses, the higher doses to target volumes. Again, we can consider to use more conformal radiotherapy technique like brachytherapy or proton therapy to reduce integral dose, so we have a different modality to adapt treatment when patients are radiosensitive.
What do you think of Neolis radiosensitive predictive tests? Do you think that they are suitable to be used in a clinical routine?
Yes, for sure. These tests could be used in the clinical practice because they are very fast, clinically pragmatic, and minimally invasive to the patients. And more important, they can study the relationship between toxicity and radiosensitivity.
And do you think that this test may help to adapt the treatment of patients?
Today we have several methods to adapt radiotherapy treatment. We can choose between different RT techniques. We can think to use during treatment image-guided radiotherapy or adaptive radiotherapy. We can decide to give lower doses to prophylactic volumes. We can decide to move towards protons instead of photons.
So, it's the end of the interview. Many thanks, Dr. Orlandi, for your time and to answer to my question. And if you need more information about the test, contact us.